Hello and welcome to Diabetes Recap. Every patient suffering from type 2 diabetes will have an individual glycemic control target, but for the majority of them, we want the glycated hemoglobin to be below 53 millimole per mole. If the treatment target is not reached within 3 months of treatment, the treatment should be reviewed. The first-line drugs are metformin, sulfonylurea, and insulin. Metformin. This medication effectively reduces glucose levels. It's cheap and assists in weight loss. It's beneficial for patients with obesity and cardiovascular problems. Watch out for GI upset, especially in patients on immediate-release formulations, vitamin B12 deficiency with prolonged use, and lactic acidosis. Metformin comes in two different forms, immediate-release and controlled-release tablets. Controlled-release tablets are tolerated much better and taken once a day. Don't forget to adjust the dose of metformin for creatinine clearance if it falls below 90 ml per minute. When switching from immediate-release to controlled-release tablets, the total daily dose should be the same. If our patient needs more than 2 grams of metformin a day, they should use the immediate-release tablets and not the XR. Metformin comes in combinations with DPP-4 inhibitors, SGLT2 inhibitors, and glibenclamide, the representative from sulfonylurea class. Sulfonylurea, also a very effective class of medications. The main concerns are weight gain and hyperglycemia. It is very important that these medications are taken with a meal. So we've got glibenclamide, gliclazide, glimepiride, and glipizide. Glibenclamide exists in a combination with metformin, as mentioned just a moment ago. Gliclazide comes as an immediate release and controlled release tablet. According to AMH, 30 mg of controlled release tablets is equivalent to 80 mg of immediate release. This needs to be taken into account when switching dosing forms. Gliclazide controlled release tablets and glimepiride are taken once a day only. If glycemic targets are not achieved with the first-line treatment option, the second-line drug should be added. The treatment should continue for 3 months and the efficacy should be reviewed. According to the ETG guidelines, if glycated hemoglobin didn't get reduced by more than 4 millimole per mole, the added drug should be stopped. The drug choices include the drugs from the first line, plus SGLT2 inhibitors, DPP-4 inhibitors, GLP-1 receptor agonists, and acarbose and thiazidinediones may be considered but are not preferred. Sodium glucose cotransporter 2 inhibitors, SGLT2 inhibitors. They are slightly less effective in reduction of glycated hemoglobin, but come with extra advantages of weight loss, cardio, and renal protection. Patients on this class of medications are literally peeing the sugars out. This may cause genitourinary infections, so it is important to advise our patients about the importance of hydration and hygiene. SGLT2 inhibitors may also cause euglycemic ketoacidosis with normal glucose levels, in patients not consuming enough carbs, which could be seen in patients who are fasting, unwell, or undergoing medical procedures. The wonder drugs of this class are being used for other medical conditions. For example, empagliflozin has been recently approved under PBS for treatment of chronic heart failure, and they can slow down the progression of renal impairment. Unfortunately, SGLT2 inhibitors become ineffective once the renal function declines significantly. We've got dapagliflozin, empagliflozin, ertugliflozin. All of them come in combination with metformin and DPP-4 inhibitors. Dapagliflozin and metformin, dapagliflozin and saxagliptin, empagliflozin with metformin, empagliflozin with linagliptin, ertugliflozin with metformin, ertugliflozin with sitagliptin. Dipeptidyl peptidase 4 inhibitors, DPP-4 inhibitors, allow incretin hormones stimulating insulin secretion to live longer. More insulin is being produced, glucagon is getting reduced, and the gastric emptying is getting slower. They are normally well tolerated but may cause aches and pains in muscles, and there were reports of pancreatitis. The dose will need to be adjusted in renal failure, with an exception for linagliptin. Saxagliptin and alogliptin are not recommended to be used in heart failure. The representatives are alogliptin, linagliptin, saxagliptin, sitagliptin, vildagliptin. They all come in combination with metformin. Alogliptin and metformin, linagliptin and metformin, saxagliptin and metformin, sitagliptin and metformin, vildagliptin and metformin. As mentioned before, saxagliptin, sitagliptin and linagliptin come in combination with SGLT2 inhibitors. All DPP-4 inhibitors are taken once a day, apart from vildagliptin that can be taken up to twice daily. Glucagon-like peptide-1 agonists, GLP-1 receptor agonists, are analogues of glucagon-like peptide-1. They act as incretins, increase insulin secretion, reduce glucagon, and slow down gastric emptying. They've got a few pros and cons. The pros are the efficacy on glycemic control seems to be similar to metformin and sulfonylurea. They can cause significant weight loss. They have shown cardio and renoprotective properties, at least dulaglutide and liraglutide, and they are unlikely to cause hypos. The cons are, in Australia, they are only coming as injections. In other parts of the world, semaglutide exists in tablet form. There were also some reports of pancreatitis, thyroid, and other types of cancer, and they may not be suitable for patients with severe renal impairment. GLP-1 receptor agonists should not be used together with DPP-4 inhibitors, as they do the same thing at the end, and there are no added benefits for this combination. The representatives are dulaglutide, or Trulicity. It's a once-weekly injection. Exenatide, Byetta, twice-a-day injection, comes in two different strengths for dose adjustment. Liraglutide, Victoza, once-daily formulation for treatment of diabetes. Liraglutide also comes as Saxenda, marketed for treatment of obesity. Both come in pens, the same concentration, the same volume, and contain the same active ingredients and excipients. The recommended dose for treatment of obesity is normally higher though. Dose of Saxenda for obesity will be up to 3 mg once a day, and Victoza that is used for diabetes will be used up to 1.8 mg daily. Semaglutide, Ozempic, injection administered once a week. Comes in two different pens. 1.5 ml pen can be administered in the doses of 0.25 mg and 0.5 mg, and 3 ml pen that delivers 1 mg doses. Normally, our patients would start with a low dose and gradually increase it to the effective and tolerable dose up to 1 mg a week. Semaglutide seems to be the most effective GLP-1 receptor agonist for weight loss. However, weight loss is the drug class feature, so all representatives of this class have this effect. Acarbose interferes with the absorption of carbs from the diet, so normally is taken just before a meal with the first bite of food. Not a very well tolerated medication, with many patients complaining of diarrhea, flatulence, and stomach pain. Also, not as effective as sulfonylurea or metformin. Thiazolidinediones increase sensitivity of tissues to insulin and offer some beta cell protection. Just like sulfonylurea and insulin, they can cause some weight gain. The use of this drug class has been associated with increased risk of fractures, heart failure, and macular edema. Some of the common side effects are peripheral edema and muscle aches and pains. The only drug in this class in Australia is pioglitazone, or Vexazone and other brands, and it's taken once a day.